Hello my dear students, welcome on this session. On this interesting session we are going to discuss anxiety disorders. Have a look at this board, and this is telling you a bird's view of all the anxiety disorders. Here the stressor is absent and here the stressor is present. The stressor is absent. You get generalized anxiety disorder, GAD, panic states, and OCD, that's obsessive compulsive disorder. Stressor present, obviously, phobias, post-traumatic stress disorder, PTSD, and acute stress disorder, ASD. Apart from all this, down what I'm writing is the anxiety disorder due to general medical condition or the anxiety due to substance abuse or withdrawal. So this is exactly separate from the anxiety disorders proper, which we are going to discuss. So let's start the discussion of these interesting anxiety disorders. In general, there are symptoms of fear or worry without adequate cause. Then you call it as anxiety disorder. Otherwise, you can be anxious in normal situations. But when we use the word disorder, it means the symptom of fear or worry is without adequate cause. And it may be for extended period, at least 6 months. And it interferes with the normal functioning and leads to significant distress. The symptoms and the manifests of anxiety are shakiness and sweating, that's the sympathetic overactivity. This also leads to tachycardia, palpitation, increase in the blood pressure, breathlessness and chest discomfort. If you look at the pupils, there's mydriasis. In the gastrointestinal system, it leads to increased GI motility in the form of diarrhea. In the urinary tract, there's increased urinary frequency, and there could be hyperventilation, which could lead to dizziness or syncope. There's tingling in the extremities and face. So all these are classical symptoms or manifest of anxiety. The anxiety may be situational anxiety or it may be free-floating anxiety. According to the DSM-4 classification, what I have written on this board, the stressor is absent in some conditions. This includes generalized anxiety disorder, stressor is absent and the disorder is quite chronic. The next one is panic disorder, stressor is absent, this is an acute condition. And obsessive compulsive disorder, OCD, again, the stressor is absent. The three situations in which the stressor is present: specific and social phobias, post-traumatic stress disorder, abbreviated as PTSD, and acute stress disorder, ASD. Apart from all these 6 disorders, we separately mention anxiety disorder due to a general medical condition or the substance-induced anxiety states. When you think of anxiety disorder, you need to differentiate anxiety disorder from certain conditions. For example, use of caffeine leads to sympathetic overactivity. You can have the symptoms of anxiety. Then substance abuse or withdrawal, as we already mentioned. Conditions like hyperthyroidism and pheochromocytoma, in both you get sympathetic overactivity and you get the symptoms of anxiety. Hyperglycemia as well as hypoglycemia, both can lead to anxiety symptoms. Situations of anemia, B12 deficiency, cardiac arrhythmias, and chronic obstructive pulmonary diseases, COPD. All these are the differential diagnosis of anxiety. At the same time, we must remember some psychological conditions, some psychiatric conditions which look like anxiety, or it may be present in comorbid depression or in dysthymia. Patients with schizophrenia, especially when they are in the prodrome or they are in the psychotic phase, can present as anxiety. And the patients with hypochondriasis, which have distress about having illness, hypochondriasis. This is another situation which could be a differential diagnosis of anxiety. So all these things you need to keep in mind. You need to rule out all these conditions and then you can label a particular patient as having anxiety disorder. Let's start the discussion with the first disorder, that's generalized anxiety disorder. In this, the patient has hyperarousal and there's excess worry which lasts for more than 6 months. And the anxiety may be situational or may be free-floating anxiety. This could exist comorbid with depression sometimes, and the onset is in childhood or adolescence. in 50% of patients. The symptoms are chronic and they worsen during the stress. And because it's a chronic disorder, you need treatment for long periods. What's the treatment? We need anti-anxiety agents, and a novel anti-anxiety agent is buspirone. It's a 5-HT1A partial agonist. You need to remember this special mechanism of buspirone. Otherwise, whenever we speak of anxiety, you might be thinking of benzodiazepines, which act on the GABA receptor. And naturally, this GABA receptor is associated with the properties of sedation as well as the properties of dependence or habituation. But buspirone is different. It's a 5-HT1A partial agonist, and it has got minimal sedation or no sedation, and the abuse potential is very low, and there are very less withdrawal symptoms. That's the great advantage of buspirone. Only thing to be remembered is the effect is not acute. You cannot think of using buspirone in an acute anxiety state. It takes about 2 weeks to develop the effect. So it's a slow effect, and buspirone is a useful drug for chronic anxiety. Next in order, you can use benzodiazepines, of course. Next in order, very important drugs are beta blockers. Please remember, beta blockers do not do anything to the psychological system. They block the beta receptors, and they block tachycardia, palpitation, rise in the blood pressure. So beta blockers are useful to block or to prevent the symptoms of anxiety, the manifestations of anxiety, and that's why they are very useful. There are other medications which could be useful. In addition to this, cognitive behavioral therapy and other behavioral therapies may be used to treat a patient with generalized anxiety disorder. When the same patient presents as acute anxiety condition, then you can think of using benzodiazepines again, and you can use them by intravenous route of administration because this is an emergency. You think of using diazepam or lorazepam. So just to revise, the management of generalized anxiety disorder, acute anxiety state, diazepam, lorazepam intravenous, and chronic anxiety, buspirone in the first place, a 5-HT1A partial agonist with minimal sedation and minimal abuse potential. Next in order, benzodiazepine. Next in order, beta blockers. I hope it's quite clear. Next, we go to the next condition under anxiety disorders. This was GAD was the first one, and now we discuss the panic states. The panic states occur in about 1.5 to 3% of patients, and the onset is around the age of 25 years. To diagnose a patient with panic states, sodium lactate administration could be used, or carbon dioxide. These two substances are useful to diagnose a patient with panic disease. In panic states, the patient gets episodic panic attacks. There is a sudden onset and there's increased intensity over a time period of about 10 minutes, and the attacks may occur twice weekly and it may be 30 minutes each. There are cardiac and respiratory symptoms and the patient has fear of death. There is anticipatory anxiety in between the attacks, and this can limit the function of the patient. The patient knows he is likely to get an attack, and the patient, as if he is anticipating an attack, remains in anxiety in between the attacks, and this limits the function of the patient. There are genetic factors and social factors involved in the pathophysiology of panic states. There's a special situation is panic state with agoraphobia. What's agoraphobia? It's fear or avoidance of public places or situations where escape is impossible or the help is unavailable. And this is quite a common condition, panic state with agoraphobia. These patients who have panic states with agoraphobia are likely to have been suffering from separation anxiety disorder when they were child. Management of panic disorder with or without agoraphobia remains constant. In emergency, again, we use a fast-acting benzodiazepine like diazepam, lorazepam, alprazolam. You can use diazepam, lorazepam by intravenous route of administration. And for long-term management, you can use benzodiazepines, but one of the important groups to be remembered is SSRI, that's selective serotonin reuptake inhibitors. And I hope when the 5-hydroxytryptamine levels are less, it leads to anxiety states. And naturally, SSRI, selective serotonin reuptake inhibitors, are going to potentiate this 5-hydroxytryptamine or serotonin, and they are found to be extremely useful. Just for your reminder, SSRI are selective serotonin reuptake inhibitors, are basically classified as antidepressant drugs. But when you are asked about what are the other uses of SSRI, please don't forget anxiety states. So SSRI now in first place, and or benzodiazepines could be used. And as we just discussed for GAD, you could use beta blockers in the management of panic disorder with or without agoraphobia. You could go for psychological therapies in the form of systematic desensitization or cognitive behavioral therapy. Next, we move on to discuss what is phobias. And phobias are on the right side. Look at this. This is the stressor is present. So we discuss phobias first because it goes many times hand in hand with the panic states. Phobias may be specific or it may be just social phobia. What is phobia? It's unfounded, irrational fear of things or situations. Specific phobia is a phobia or fear of a specific thing or a specific situation. And social phobia is defined as the fear of performing socially. So what is in problem is the social performance or the setting. If this is given to the patient is placed in a social setting such as speech in public, eating in public, using a public washroom or restroom. For example, there may be a person who is quite fine across the table when he is speaking to an individual. But when this person has to face the public for a public speech, then it might be in trouble. So I gave you an example of the social performance or social settings such as public speech or the using a public washroom or the restroom. So that's about the social phobia. Specific phobias, we just try to discuss some important conditions under specific phobias. Situational phobias, like you are in a vehicle and you are passing a tunnel or a bridge, or just using public transportation itself might lead to phobia. The fear of the flight, fear of using an aircraft, flying, closed spaces, this is one important situational phobia. And when it's closed spaces, you call it claustrophobia. The natural environment like lightning, thunder, heights and deep water. This is another situation which can lead to specific phobia. Some people have specific phobia of looking at blood, undergoing a procedure or watching a procedure like injection, simple procedure like injection or injury. This might lead to specific phobia. Few people have phobias of animals and insects, and the phobias to spiders is called arachnophobia. Other specific phobias, there are many situations which could include loud noise, costumed character, falling, or just illness. All these can lead to specific phobias. So specific phobia and social phobia, these are the two types. And I also include once again here agoraphobia with panic disorder. Agoraphobia with panic disorder is quite common and we just discussed about it. It is the performance in social situation or public situation. As far as phobias are concerned, there is no problem with the patient if the patient is not exposed to phobic stimulus. Otherwise, in all other situations, the patient is quite normal. And occupational or social difficulties may be encountered as far as the employment, school, or the social relations are concerned. When we discuss phobias, we need to differentiate specifically from the normal shy behavior. So you have to have a differential diagnosis as normal shyness. Again, another situation is delusional disorder. Some people have delusions and this could look as phobias, so delusional disorder. Next, some personality disorder can present as phobia. For example, paranoid personalities have got suspiciousness. Avoidant personalities have got a tendency of avoidance due to fear of rejection, so avoidant personality. And schizoid personalities, they prefer isolation, and that's why this might look like phobia. So differential diagnosis, normal shyness, delusional disorders, and paranoid personality, avoidant personality, and schizoid personality. These are the differential diagnoses for phobia. In the management of specific phobia, beta blockers are extremely useful. Apart from this, you can go for various therapies. This includes, again, cognitive behavioral therapy. Systematic desensitization could be extremely useful, and other behavioral therapies like flooding and implosion. You can also think of using hypnosis, family therapy, and psychotherapy in the management of specific phobias. As far as social phobias are concerned, the place number 1 is occupied by SSRI, selective serotonin reuptake inhibitors. Then you can think of using MAO inhibitors, which are antidepressant agents, and beta blockers. For social phobias, the patient needs assertiveness training, and the patient also might need group therapy. So that's about the management of specific phobias and social phobias. And now we again come to the left side to discuss this particular condition in which stressor is absent, that's OCD or obsessive compulsive disorder. There is recurrent, unwanted, intrusive feeling, thought or images, and this is defined as obsession. Recurrent, unwanted, intrusive feelings, thoughts and images is defined as obsession. And when the person starts performing repetitive actions is called as compulsions. So the repetitive actions may manifest as washing the hands repeatedly, checking the door locks, checking the gas jets, counting objects, and checking the light switches. The onset can be in early adulthood, and please remember, reality is intact in this patient. The ground reality testing is totally intact in obsessive compulsive disorder. We need to differentiate OCD from Tourette disorder, from temporal lobe epilepsy, and from obsessive compulsive personality disorder. So it's not obsessive compulsive disorder, it's obsessive compulsive personality disorder. Quite difficult to differentiate. As far as OCD is concerned, the top drugs which are to be used is again SSRI. Examples is fluvoxamine, fluoxetine, paroxetine, sertraline, or you can use tricyclic antidepressants in the form of clomipramine or amitriptyline. And OCDs are extremely helped by behavioral therapy and supportive psychotherapy. So that's about obsessive compulsive disease. Now we come to the stress disorders. There is S in these two spellings. Have a look at it. PTSD, post-traumatic stress disorder, and ASD is acute stress disorder. You should not make a mistake on this. You have to differentiate, and you have to remember this S. This is going to tell you that the stressor is present. So to revise or to keep in mind an important issue as far as solving your multiple choice questions is concerned, when this S is there, PTSD and ASD, stressor is present, and obviously when you come to phobia, the stressor has to be present, otherwise the patient is normal. So phobias, PTSD and ASD, stressor is present. So we discuss the two stress disorders now. This happens due to exposure to an event, for example a sexual assault, war, earthquake, fire, accident. And when the symptoms last more than 1 month and the symptoms becomes chronic for years, you label it as PTSD, post-traumatic stress disorder. Whereas if the symptoms are short-lasting, by short-lasting what I mean to say is within 1 month, that's from 2 days to about 4 weeks, is called acute stress disorder or ASD. What are the symptoms of the stress disorders? In stress disorders, the patient could re-experience, in the form of flashbacks and nightmares, the patient could re-experience the event which he has undergone. And there is hyperarousal leading to anxiety, lack of sleep, obviously, that's insomnia, and hypervigilance, excessive carefulness. In some patients, you get the opposite thing. Instead of hyperarousal, you can get emotional numbing. There's decreased emotionality. There's incapacity to obtain pleasure in the form of anhedonia and difficulty in the social interactions. Avoidance is another symptom of stress disorder. The patient has guilt about having escaped from a situation, and this is typically called survivor's guilt. You were in a particular situation, for example a road accident, and you have escaped and your friend is gone. That's a typical survivor's guilt. And these patients have this feeling, the avoidance, that's due to the guilt about having escaped. And then there's a sense of dissociation, social withdrawal, and a feeling of helplessness. All this can happen in the stress disorders, especially post-traumatic stress disorder. To differentiate the stress disorders, there are certain other situations which can look like stress disorders. One is the brain injury due to traumatic event. The person can have stress situation like stress disorder. Then adjustment disorder. The person might look worried and might look in stress, but please remember, adjustment disorder is comparatively milder and is comparatively more common. The emotional symptoms like anxiety, depression, conduct problems, and mixed emotional symptoms. This can impair the social situations, the social performance, the school and the work. And if it happens within 3 months, lasts less than 6 months after termination of a stressor, you label it as adjustment disorder. That's what I said. The duration is not long and the emotional symptoms are more present and there's hampering of your usual work. But the adjustment disorders in general are milder. The situations like divorce, bankruptcy, changing places, all this also looks like stress disorder, but in these the stressor is not life-threatening. So very important thing to talk about PTSD and ASD, the stressor has to be a serious one, has to be a life-threatening stressor. So that's about the differential diagnosis of stress disorders. In stress disorder, again, number 1, SSRI, selective serotonin reuptake inhibitors. For example, sertraline is commonly used. Anticonvulsant drugs like carbamazepine, antipsychotic drugs like olanzapine, and again, please don't forget beta blockers. They are extremely useful. Group therapy and leaderless group therapy, that's the victim survivor groups, can be used to manage these stress disorders.